Okay, thank you, everybody. This meeting is now live.
Thank you very much, Lizzie, and welcome to the Health and Wellbeing Board meeting. Please may start by finding out if there are any apologies. Lizzie, do you have any apologies?
I've had quite a few apologies, so I'll just read them out quickly. So we've had Nick Derman, so we've had to roll the Health and Wellbeing Board, sorry, not the Health and Wellbeing Board, Health Watch item to the next agenda. Annabel Buxton, Sonia Johnson, Melanie O'Rourke, Councillor Michael Karim, and Martha Early. Are there any others that I should be aware of? Great, thank you.
Me, thank you. All right. And do we have any declarations of interest with regards to anything being discussed today? Okay, do I need to read out the declaration there? No. Okay,
I don't think so, no.
All right. And are there any urgent items of business?
No, none notified, Chair. Thank you.
Okay, thank you. All right, so if we move on to agenda item number 4, minutes from the previous meeting, we need to approve these as a correct record of the minutes of the meeting of the board held on the 4th of June 2024. I've had a read and they look fine to me. Is anyone happy to second them?
I'm happy to second those, Chair.
Thank you. Thank you very much. Thank you. Any matters arising from those minutes? Okay, all right, no matters arising. On to agenda item 6, public participation. We don't have any questions that have come in, as far as I know. Is that right, Lizzie?
Yes, that's correct. We haven't had anything submitted.
All right, brilliant. Okay, so that moves us on to the health and wellbeing strategy, and that's we were going to have an update on priority 4, and I think that's over to Hema.
Yep.
Thank you, Chair.
Much. And thank you, Chair, for also highlighting one of the agenda items, 6.2 point, which I'll come to later when we go through it in terms of that complete sentence. So thank you for supporting that. So as you know, we've been bringing the dashboard of outcomes on health and wellbeing strategy and doing a deep dive on each of the priorities. And this is one of the last priorities we are doing a deep dive, which is priority 4, which is about infections and adverse weather, etc. is basically health protection. In terms of today's presentation, what I have done is 3 things that we want to highlight. There are recommendations, 5 recommendations, and I'm obviously assuming everybody's read the rationals for those 5 recommendations, which the board can agree after we've done the presentations. Talk about the dashboard on actions, where we have highlighted in blue any of the progress reports, which are new this term. And we also want to present dashboards for the coming year, because there was a request and we had been working on how can we present both the outcomes and the actions, because so far we've been doing actions, but we have to look at outcomes as well. So Shamak is hopefully here who can present. We've been looking at different dashboards across from other health and well-being boards and adapted them to best suit and well-being. His colleagues, Rabi Luka, who could him, which we can discuss, and I can go through that so that if there are any questions or anything we want to discuss, we can take it back to NHS England while there. So shall I first present what we always do is the dashboard in terms of the outcomes, which I think all of you have. But if I just highlight the key points from what we have been doing. So for priority 1, you can see there are quite a lot of blue progress reports. And one of the ones which is very useful, I think, in terms of highlighting is the children and young people's engagement in terms of the community activity and the peer support. And there have been quite a few actions around that in terms of both the mental health support teams doing some peer support in schools, Youth Line being commissioned to do some peer supports in schools which don't have the mental health support team. And also with, so BHFT have been recruiting mentors, young mentors, which is quite good. This is, and we in public health, as you know, have got health and well-being champions or young champions who look after health. So we can see now there's a whole lot of peer support and young mentors from the children and young people's aspects, because we had quite a lot going on in the community networks in adults. So I think that's quite a good progress. There's also good progress in terms of understanding the needs of children and young people. So we've just procured CSU to do some work on eating disorders, etc., which has come from following on from the pandemic, which is another one. So I think priority 1 and priority 2, there's quite a lot of good work that's been done. Priority 3, we had spoken last time, which Philip did update us in terms of the social isolation. But you can see that again, it's progressing very well with the community map assets and the training, etc., being considered to be progressing quite well. And priority 4 is what we are doing deep dive on. So I think in terms of the dashboard, there are quite a lot of good actions. And I'm presenting this on behalf of all our partners who have been doing excellent work in progressing the reports. The only one which at the moment is still red is the self-harm toolkit, which we now have a suicide prevention strategy Berkshire wide, and this is now progressing. But I haven't turned it amber because I think we need to start progressing on that before we can turn it amber. But it is now progressing in terms of what we need to do, and once we have some sort of understanding of what the toolkit would look like locally, I think we can start looking at the progress on that. So if I stop just if questions on the dashboard before we move on to the deep dive. Okay. So I see there are no hands. I hope that I can't see everybody, but I hope there are no
Okay,
hands.
I can't remember how to put my hand up on Zoom. Just having a look. Was it here
I think
reaction?
Nicola is waving, so I don't know whether she's.
Right, Nicola, have you got a question for us?
I've just found the button to raise my hand. So yeah.
Right.
Hema, am I right?
No.
I think it might be Suicide Prevention Day today. And I was reading something online about how important it is to talk about suicide and suicidal thoughts. And there's a very short training video, I think, about how to help people talk about those thoughts. And there's no evidence to say that talking about it makes it happen. And I just wonder, Hema, if that's part of our strategy in terms of all our staff and the contacts we have feeling confident about talking to people who are having suicidal thoughts, and whether it would be worth sending round the very short link that is informative to people.
Thank you, Nicola. That's a very good point you have raised. In fact, at the East Berkshire Suicide Prevention Strategy, we had a presentation from the local, not the local charity, the national charity, which is Hope of Peyton, which is one of the suicide prevention. And they have been working on a suicide pledge. It is about increasing awareness, getting people to talk about suicide. And they have been working with a lot of organizations, not only the public sector, but also businesses, large businesses, which seems to be working very well. The evidence from that is people talk about it, it raises awareness of suicide. So one of the actions we took from the East Berkshire, and there were friendly people also there, Aidan was there, and we had people from BHFT, that we should, as an organization, as all organizations friendly, we should look at signing on this pledge. So we are looking at how do we sign on this pledge as a system, so that we, and there are 3 different layers: bronze, gold, platinum. So it makes it easier to, I think, increase awareness, but also reduce the stigma associated with suicide, because there's still a lot of stigma, as you know, associated with that. So yes, Nicola, I totally agree. That's something that's we're taking steps on.
I'm just okay. Thank you. Sorry, I just had a couple of questions on priority 2. We talked about eating disorders and self-harm, and I was just wondering where we'll be able to access data about the scale of the problem.
Yes.
It's just be good to get an idea.
So we have, together with SLAW, we have just gone through procurement, and we've awarded the reward to the CSU, the local CSU, in terms of doing an interactive tool for us where we can look at granularly eating disorders, low-level emotional health, etc. So hopefully that will allow us to look at across Bracknell Forest and Slough and we had obviously good engagement from BHFT and others that this is something which we could work on. So that's starting soon. So we should be able to have that by end of this year.
Okay, thank you. And then my other question was on point 16, MHST. Is that mental health in schools team or something?
Yes, mental health support. Yeah.
And so then my question was how are we measuring the outcomes here?
Mm-hmm.
I think I can't remember what that was
Yeah.
with regards to. Yeah, I imagine it's Go on, tell me, Hema. Sorry.
So the good news is that Bracknell Forest has got another mental health support team. So in the current round of wave, Slough has got one team and Bracknell has got one team. They do collect a lot of information in terms of both the schools, how they are looking at embedding mental well awareness of mental health and mental well-being within the schools, but they're also collecting data on number of students who are referred into or who are being assessed through the mental health support teams. How many of them are signposted to camps? How many of them are provided other support? So we do have that data. I think we had a presentation, and we can perhaps circulate the report from MHST just as to make awareness of the data that comes in. But that will be also sitting in the new dashboard that we are presenting, which Shamak will present.
Okay, thank you. And then my last question on, and I've got two more questions on priority 2. My other one was about the Happiness Hub. There was an unsuccessful bid from Youthline for early intervention, and I just wondered, is that mean that are we going to try and look for funding elsewhere, or have we just kind of had to sort of abandon that plan?
So the idea was that so Youthline was already had that put in a thing, but I don't think we are totally abandoning it. We are looking at ways of which we can replicate the happiness hub, which is for adults, for children. So again, I think through the transformation plan and others, we'll look at ways of how we can do that. One example is that they're looking at some funding that they have secured or released from the transformation plan is to use something like the Arts Center, the Southfield Arts Center, or similar, to work with children who are neurodiverse and their families to see how we can do some sort of because it's about, I think that was the group which we all felt perhaps needed more in terms of that community happiness hub type of support. So that exploration is happening at the moment through ICB.
Okay, fantastic. And then my last question was on point 22 on priority 2 was mapping of current reach of lifestyle services to people with emotional and mental health issues and conditions. I just wondered what you meant by lifestyle services. I couldn't quite work it out.
Yeah. So we have lifestyle services like smoking cessation, adult weight management, physical activity. So ensuring that we have equality and inclusive of people with mental health problems are included in accessing those services, how we support them.
Okay, fantastic. All right. Well, that was all my questions on priority 2. Does anyone else have any more questions on the dashboard? Okay, thank you. Oh,
Okay.
Nicholas, you? Are you okay? No. All right. Back to you, Hema.
All right. So I think I'll go to the deep dive before we come back to. Have I lost everybody?
No.
Sorry, I've got quite a few things open on my system. Yes, if we go to the deep dive, then perhaps I can come back to Shamaki to do the dashboard. That will give you an idea about how we are taking some of the more deep dives into the outcomes. So if I share, because you all have had the slides, but I'll just go through a few highlights in the slides and ask if anybody has any questions. Okay, I am going to share screen. Can everybody see that?
Yes, thank you.
Yep.
Okay, so just to this is a screening and immunization update from NHSC. As you know, NHSC are the commissioners, and a lot of programs are provided by different providers within the NHS. And the two big ones in terms of screening are the pregnancy and newborn and adult screening program. And then we'll go through they've also presented data on immunization, childhood immunization and other immunizations, and then a little bit about what's happening new. This is quite good because this is the first time after a long time we have actually had good reports from NHSC. So I think this is very positive in terms of assuring the Health and Wellbeing Board about the performance of screening and immunization, which is something we have a role in terms of the assurance from local authority's role. So just firstly, very quickly, in terms of the pregnancy and newborn programs, one of the first things I want to say is Bracknell Forest is doing quite well, both compared to the national performance as well as within Southeast and East Berkshire. When we looked at the data, we are performing quite well. So that's something which is quite something to note for us. You will see over here that there are all the different
Hema, just to
screening.
interrupt, I'm not sure that
Yeah.
your slides are moving on. Can anyone else?
Oh,
I'm still on the
No.
first page.
Yeah, me too. Maybe if you're in slideshow, does that help?
yeah, I did start the slideshow, so I don't know what's happened.
I think we can see your main PowerPoint screen rather than the slideshow itself.
Okay, let me escape from that and see. Oops, it's gone to. I'll just stop sharing for a minute and then see if it is helpful. Oh, there seems to be a problem on my side.
Would you like me to have a go, Hema?
Yeah, if you can, that would be great.
Yeah.
I can only see a black screen, Lizzie. Oh, there it is. Good. It's coming black for me. I don't know about others.
Same for me as well.
Sorry, everyone. I just lost my
Ah,
lost
there we are.
control of it. There we go. So where were we?
I think we've done that one. Had we done that
Yeah,
one, Hema?
we've done that. We've done that. Yeah, we've done that. The next one. So if you come to this, the data. Yep. Next one, please. Okay, so this is the one which is a pregnancy and newborn, and you can see there are infectious diseases, the physical examination, so hearing, etc. And then there's a sickle cell, so the three lots. And if you look across for Bracknell Forest, Q4, which was last year, and then Q1, Q2, Q3, you can see a lot of green, which means we are meeting the achievable standards. The only ones which we are perhaps at an acceptable standard. So, you know, they've looked at, they've given two things, which is what is the lowest threshold and then what is good. So we are still meeting the lowest threshold in newborn and infant physical examination, timeliness. And I think this is something it's improving. So if you can see we started off with 57, but we moved on to 84. So I think from that perspective also, it's good to see it's improving. If you go on to the next slide, this is the other screening program. So these are the adult screening programs. So we got the two cancer screening programs, and the other one is the aortic aneurysm. That is about those who've got an aneurysm in the aorta, abdominal aorta, and then we've got the diabetic eye screening. Again, if you look across, there are some greens, but we are meeting some of them are just meeting the lower threshold. And some of this may be, if you look, and when you compare it to the national standards, we are still better, which is quite amazing. But some of this maybe we are coming out of COVID. So there's something about waiting for another year to see how we've recovered coming out of COVID, because we do know a lot of these providers are hospital providers or GP providers. So there's something about how we ensure that. In terms of breast screening uptake, I did talk to NHSC because we know the evidence base for text messaging is quite high. There are randomized controlled trial. And what I was told that they are looking into this, so they are rolling out that text messaging in our patch as well, the Southeast. So hopefully that will see an improvement for Bracknell Forest as well. So I don't think there's anything which is below acceptable threshold, and we are improving in some of them, and some of them are static. But I think we need to wait for perhaps another 2 quarters, as I said, as we are coming out of COVID. And if you go on to the next slide, this is just coverage comparing Bracknell Forest with England, just to assure ourselves that we are not actually doing any, we are better than, or we are at least similar to the national programs. And you can see some of the programs we are doing better than the national. And this is true also when we compare ourselves in Southeast or Berkshire. However, I think we should be aiming or aspiring to meet the national standards for all of this, because it's about benefiting and the value from what we're investing. So we'll be working with our NHSC colleagues and ICB in terms of how, and Sarah Bellas is already doing an implementation plan. If you move forward, I think the next few slides are not that important. They have added them, but these are just trends by year showing us how things have happened. It's important to remember cancer mortality, because the cancer screening programs are mainly to reduce the mortality from cancer, because if we do catch them early, any symptoms, etc., there is good treatment in terms of increasing the survival rates. So just to remind people, screening is about bringing in the most at-risk population, which are otherwise healthy, to see and put them through a test to see if they have got any symptoms or any conditions that can increase the risk. But also if we catch any symptoms that are early, we can reduce the progression to, more about cancer, but it's about reducing the impact of what they have. So some of the cancers we know are preventable if they're caught early. Some of them you can improve their survival rates. If you move further, obviously this doesn't consider lung cancer because that's smoking, which we talked about last time when we did priority 5. These are childhood immunizations for Bracknell Forest. And again, I think for childhood immunizations, what we should remember is that 95% of the population, if we get the coverage for 95%, then that's herd immunity. Some of them we can see we are green. One of the things which, and others are achievable, acceptable standard, but I think the acceptable standard normally is in the 5 years old, etc. But above that, I think the main things we need to see is the ones which are on green. And again, it's how do we ensure that we are reaching the national standards. So 95% is what we would like to achieve. But we are not below the acceptable standard. So that's something I think we need to be assured about. If you move forward. And the one which I was mainly looking was MMR, which is not bad compared to, where we were a few years ago. So that's improving. So that's good. Can we move forward? Because I'm just mindful of the time. And then we've got the new RSV vaccination, which our plans are in place. From 1st of September, those who were 75 to 79 were called by the GP surgeries, and pregnant women are being called within the vaccinations being delivered by maternity services. So we will be getting an update on that later. The only one thing, sorry, I forgot to mention, the other one was where we need to perhaps focus in immunization, not the childhood immunization, but the adult immunization, is flu vaccination, because we can look at those who are at risk of impact of getting flu, if they get flu, are people with comorbidities, and our vaccination rates, and this is national as well, the vaccination rates in those population is quite low. And if we can increase that, and I think that's something which we should look at in terms of increasing those uptake in that population. If we move to the next slide, this is just about, what are the rules. I'm not going to bore you with this. You all know about this, but this is just a reminder. That is why we put a recommendation, is that this is a joint work. If we move forward, besides the infectious disease, we're looking at winter mortality, and we know the impact, direct and indirect impacts of winter. So what can we do to make sure that we are reducing the deaths in winter? Because we all know that winter deaths are higher, and we need to compare that with our normal rates, and what can we do to reduce the winter mortality. If we move forward. So this was just telling about how we are working together. There's improved collaboration, as I said, and we are really now getting good data and good reports, and we can actually also go in the future NHS and look at them ourselves. Although they're a bit dated, we can still look at them. If we move forward. Inequalities is something which we want to look at, and while there's been work undergone in terms of how we can engage with certain communities, especially with the inclusion health groups, easy read guides, translated materials, MEC training. So there's quite a lot of things happening within that to reduce tackling inequalities. Next. I think that was the end of this. There's something on adverse weather planning, which I don't know with Gabby, if she is joined. She was going to give a verbal update, but otherwise I can just talk a little bit about it. So I'll pause here, and if there are any questions.
Thank you so much, Hema. I can see Andrew's got his hand up. Andrew?
Yeah, just 2 points. So in terms of that sort of flu vaccination and working collaboratively together on that, I assume that that is going to be key for us now as we move into sort of the winter pressures time. And so what are we doing as a collective entity on that point? And in terms of the data, I mean, the general picture, and Charlotte and I have talked about this, is that, the affluent are kind of masking perhaps some of the disparities in where we might be seeing immunisation not being taken up. Is there a set of data that we could get beneath that, so we could start understanding if that's particular groups or particular localities? At the moment, we're just looking on that sort of that Bracknell Forest geography, but is there a way of digging deeper that would help us then to do targeted action, I suppose, are my questions.
Yeah. So I'll answer the second question first, Andrew, if that's okay. So that's one of the recommendations we've asked, and we have been asking, because the data sits with NHSE and GP practices. So we have asked if we can get data which is granular, either at GP practice level, which they're looking at how they can support us in getting data at GP practice level, or at ward level or super output area. So they will look at how they can support us in that. That will give us whether there is. I think if we are achieving the 95%, I would presume that perhaps most of the communities are taking up that. I think where we are falling below that, especially in the flu vaccination, etc., I think that's where we need to perhaps focus in the front one. I agree with you on that one. In terms of what we are doing, there are a number of things. There is the group which is set up by Sarah Bellas, which looks at inequalities, and they are able to perhaps look at from within the system, NHS system, they are able to look at which communities are not taking up. So there is some work happening at a system level, and how we support that through communications and community engagement is important, like we did with COVID. The other thing which we have been doing is we've been working with the 6 communities within Bracknell Forest, which are the largest minority groups. So we are looking at the community profiles and doing World Cafe to understand their understanding of various health issues, but also raising the awareness of the various services that are available. So we've done one with Ukrainian. This Saturday we did with Nepali community. So from a local perspective, that's how we're engaging with communities as well.
Thank you. We don't have numbers on Zoom, so I don't know who put their hand up next. Is that you, Nicola?
Oh, I think so. Just a few points from me. One, backing up Andrew's point about yes, let's try and improve vaccination, but outside the meeting, Hema, maybe we could develop a plan of what we could all do to do that. We have a short window of time. It would really help the pressures on all of us if we could up that uptake, which is not very good English. Secondly, I saw in the recommendations the recommendation about focusing on inequalities, and we talk about geography and ethnicity. I don't know if the board are aware, but people with a learning difficulty have a 30% difference in their uptake of cervical screening and over 20% in terms of breast screening. So, Hema, I just wondered if consideration had been given to focus on that particular cohort of people we have in our community as well. And there's finally, Hema, it's a very small point. There were some examples where we didn't meet the minimum threshold in your data pack. Young women and cervical screening uptake was one of them. I think we should flag those clearly in red. There's a very small number, and in general, it's a really good performance, but there were a small number of areas where we're not meeting the minimum thresholds.
Okay, yeah, I think maybe I didn't see red. I thought I agree with you. I mean, we definitely need to focus on those, and this is where which I mentioned, the text messaging, because the randomized control trial very much indicated that it's those young women who, if they're reminded through text messaging, are likely to take up a lot of time. It's just because they have got the behavioral insights show that it's not that they didn't want to take up cervical screening, but they just forgot about it because of the busy schedules, either they've got college or they've got work. So I think it's quite important that reminder through text messaging. And this was also true for deprived areas. Women in deprived areas also took up cervical screening when you do either cervical or breast screening when you do text messaging. So hopefully they're going to be doing that, rolling that out. And we need to make sure that we are just working with them, because it's not only about text messaging, but the language of text messaging and allowing them to, it's a two-way system, so allowing them to rebook their appointment, especially for breast screening, if they can't meet that. So yeah, there are good evidence-based interventions that are already known, so we should be using those.
Thank you, Hema. And Charlotte, do you have a question? And maybe Charlotte, introduce yourself if this is your first Health and Wellbeing Board meeting. Thank you.
Yeah, of course, Chair. Thank you. I'm Charlotte Pavitt. I'm the Director of Public Health, newly appointed at Bracknell Forest Council, so working very closely with Hema and the team. Yeah, thank you, Hema. That was a really useful overview. I guess from my perspective, it's just reiterating that importance of the granularity of the data. And I think we do need to push NHS England to get that data on a more regular, systematic basis. I know that they've shared it before, and we have insight in terms of school level data. I haven't had view of that at the moment because I've only been in post a few weeks for Bracknell Forest, but actually in other local authorities in Berkshire, that uptake is as low as 40%. So that means in that school, there isn't herd immunity, and should measles come back from the school holidays into that school, we're looking like a mass outbreak. So that is a risk, but at the moment we don't have that understanding and that knowledge, and we're therefore not assured in terms of protection. So I think for us, we need to take an action. I'll take that back to the Health Protection Board, and we can, where NHS England do have membership, and we can see and explore about getting that granularity of data on a more systematic basis so that we can learn from that. The other point that I just wanted to raise in terms of some of those orange stroke red figures, I think we also need to go back, both public health and working with our ICB colleagues, in terms of seeking assurance from our providers that they have robust core recall processes, that they have the understanding of which of their patients haven't been vaccinated or haven't received screening, and that they've got the necessary mechanisms in order to target and to make that service available for those individuals. And where that's not happening, then we can look at what the evidence base is suggesting in terms of offering support for further intervention. And again, Hema mentioned the ICS ICB group that's looking on immunisation and inequality, and Public Health will look to go along and explore that a little bit more as an action too. So it was just those key points that I wanted to make, and of course we will prioritise the flu vaccination support where we can, because actually we do have control over some of those avoidable illnesses in terms of flu prevention. So be keen to pick that one up offline, Nicola.
And just to add to that, Charlotte, is we did ask NHSC, as you remember, that previously whenever there was a quality assurance, DPHs were informed and were part of that process. So we've asked NHSC why at the moment we haven't been getting those reports on quality assurance, so that we know that if there are any fails and systems have failed, we are made aware of it, because that's the whole idea of the assurance bit. Yeah.
Okay, thank you, Hema. I know Nicola wanted to come in and say something about the data.
Yeah, and you've kind of covered it already, Hema, but just to mention, I've heard both our Chief Medical Officer and Chief Nursing Officer talking about using our connected care insight data as well to help us understand our vaccinations and immunisations at a granular level. So do encourage that conversation through the system group that's already there. We're really keen to address the inequalities piece as well as the overall rates.
Thank you. Okay,
Okay.
so if there are no more questions, I suggest the recommendations are first agreed, and then Shamaki can do the piece on the dashboard so that you can give feedback. So the next time he can bring the final one.
Okay, I just had a point to make. We were discussing this yesterday, and I'm aware we're going over. You were only meant to have 20 minutes, and we're already almost up to 40. But one of the things we were discussing yesterday was Mpox and vaccinations for Mpox, and that sort of bubbling in the background. Is there any contingency plan for that across the NHS, or is there any plan on that? I can see Charlotte's put a hand up. Charlotte,
I'll let her answer because we haven't discussed it. Charlotte, do you want to answer that one?
Yeah, of course. So from a local perspective at the moment, the national line is that the risk of Mpox to the UK as a whole is very low, and that there's no local response or preparedness required at this moment in time. That said, we are looking at public health budget lines and ensuring that we do have a health protection contingency identified within the public health grant in a sustainable way moving forward. So this is one example of an infectious disease where we haven't got control over what's going to happen locally, and actually when it comes down to managing outbreaks, it's not always clear who has responsibility over the funding. So I think from a risk perspective, it's important to have that local health protection contingency, but with the example of Mpox at the moment, risk is low, national planning is underway, vaccination is not looking to be delivered in a preventative manner at this moment in time due to finite resources in terms of the vaccination supply, but the vaccination will be used for prophylaxis for those who are exposed. So yeah, just to be assured locally that we aren't having to stand up any local response.
Okay, thank you, Charlotte. And so from there, before Shamaki goes to his, should we note your recommendations that were in the paper? And I can't remember what I meant to do formally on this. We're just meant to say they're noted. Okay, all right. Thank you very much. Thank you, Hema. Now let's hear about the dashboard.
Yeah. Shamaki, very quick, can you just say how we are doing the dashboard?
Thank you.
Sure. Hi, good afternoon. My name is Shamar Yessa. I work in the Bracknell Forest Public Health team. I'm a public health analyst. I think I've met most of you before in some meetings, but if I haven't, then good afternoon. Nice to meet you all. So in support of the health and wellbeing strategy, I've been working on a dashboard that captures the outcomes as well as any progress over a set period of time. so that it sort of empowers and it enables anyone who's interested in looking at and following the progress with our strategy to essentially access the data, have a look at the latest figures, as well as how we're doing against any set targets. So what I will do is I will share my screen. I've worked on the priority 4, and because priority 4 was presented, I thought it fits in well with what we're discussing right now. So I'll just share my screen. Hopefully there aren't any technical glitches. Are you able to see my screen?
Yes.
Okay, so I'll just go to full screen. So for each of the 5 priorities, I've developed just a cover page which tells you what the priority is, why it's a priority, the outcomes we plan to deliver, as well as what the success indicators will be that we're going to use to monitor progress. So it's very much in line with what is already in the health and wellbeing strategy document. So at the top right, you'll find a sort of toggle that will take you to the summary page for the indicators. So you can just sort of click that here, and what that should show you is for each of the individual indicators associated with the outcomes, you'll have a KPI card or an outcomes card, which will tell you what the latest figure is. It's color coded, so it tells you whether or not we've actually met the set out target, as well as the dates that the value is for. And you're able to go through 3 pages where you find the individual indicators all associated with priority 4. So you've got the screening outcomes, as well as some of the vaccination ones, and that continues here where you have more of the vaccination. So it follows the same theme. And as you notice with some of them where there's red coloring and there's a and when there's a symbol sort of letting you know to sort of be sort of on the lookout for that number, it's all linked to the actual value, the actual target value. So for example, vaccination coverage, PCV boosters, based on the latest annual data, which covers up to end of the 2022-23 financial year, gives you the actual goal, which is 95%, and where we're at. So it's very much sort of there to sort of catch your attention. So if we go back to 4.1, behind each of these individual cards, there's more information. So if you wanted to know more about breast cancer screening, which was previously discussed when he presented, you can sort of click in here, and what you'll find behind each card is another page, which has, again, the summary value, the current trend, so the percentage coverage over this 5-year period, as well as how we compare to the regional and national comparators. You're able to click into this and sort of, it's very interactive. You're able to click into this. You're also able to copy the images with or without captions, should you require it in your own presentations. So beneath the 3 visuals, you'll find 2 boxes. One which tells you or gives an indication as to why this indicator is important, why we're tracking it. So it kind of explains there the importance of tracking breast cancer and what is actually being captured using the indicator. And on the right, under the what does this mean box, you get a summary of what the actual figures are telling you. So where we're at currently compared to our targets, the minimum acceptable target and the achievable target, as well as how we compare to regional and national comparators. I think there's definitely flexibility in here in that we can sort of look and decide what we want to put in these boxes. So sometimes we wanted to include specific actions to improve current performance. We've got the space here to include that. And essentially, what the goal is to create something similar for all of the indicators that are associated with each of the priorities. So I'll just leave the screen. So that, in a nutshell, is what we're currently working on. I've got very much open to any feedback. So if anyone has any questions, do let me know. I'm unable to see, so I'm not sure who has his hands up or who doesn't have their hand up.
Thank you. Has anyone got any questions?
Yep.
Sorry, I can't say it right. Hold
Oh,
on.
Shamaki, can you stop sharing? Is that all right?
Okay, yeah, sure.
Oh yeah, and then we can say right.
Yeah,
Right, go
there you
for it,
are.
Andrew. Thank you.
My only point was when you get through to the data and there's the boxes at the bottom, where we're not on target, I would have thought we would be wanting to say what the action, specifically what the action we're taking to bring it back onto target or above target. So it almost feels like that should be in each one should have current actions being undertaken, even if there's none being taken, because then we can see that, what we're doing to try and improve the position as opposed to just what the position is, if that makes sense.
No, that makes complete sense, and there's definitely space there to do that. So I'll add it on my sort of to do. What I can also do is I could perhaps even create a separate page that just summarizes indicators with the actions on a separate page. So yeah, there's definitely the flexibility, and I agree that should be included within the dashboard.
Chair, can I come in? I think so. Andrew, you're right. What I was suggesting is what you have suggested is at the moment we've got a separate actions dashboard on which we've been, but we can do this together. So now we can just put under each of them what are the actions and how are they progressing. So from the delivery plans, we can just put them in that.
Yeah. So you've got a single view of the of what you're trying to achieve, where you're at the moment, and what you're doing to get to it is. So it's all in one, single view. That'd be brilliant. It looks great.
Thank you. Nicola, did you have something to come in on?
It was really just some positive feedback. I know how incredibly difficult it is to do these dashboards and get this amount of data in one place. So I think you've done a really good job. And then secondly, you might just want to add a how to use something at the front. I always forget what to click on to get where and get lost. And I suspect I'm not the only one. But yeah, really great job. Well done.
Thank you, and I'll just echo that. I think it looks fantastic. I had a quick question about who will this be accessible to? Like, is it going to be publicly accessible or just so what's the plan with it? I mean, it looks fantastic, but obviously it's going to be quite a big job to keep that up to date, especially if it's being viewed by the public. So yeah, it'd just be interesting to know.
So depending on the actual nature of the data, some of it would be publicly available, some wouldn't. There are certain indicators that capture that just we're not able for the obvious reasons to actually have that. But I think for most, there is the possibility. So what we can do is for most of the indicators to have that available publicly. In terms of upkeep, it's actually the hard bit's actually designing, putting the dashboard together because it's all linked to sort of Excel spreadsheets. In terms of upkeep, every quarter or perhaps monthly, I can then sort of refresh, add the data, and it'll just sort of all click in because it'll sort of link to a single sort of data source. So upkeep shouldn't be an issue at all in terms of having publicly available. That's absolutely possible, and it can be presented on our JSNA page or another online page. But for some indicators, we might not make them publicly available simply because of the fact that we can't share it outside of our organization.
Or maybe we could have a sort of vetoed version available that we agree on. Nicola, see your hands up.
Yeah, it was just to get a collective view from the Health and Wellbeing Board. I would think that we'd want to make as much public data available to the public as possible as part of our responsibility around openness and transparency. And of course, we talk about it in this meeting. That's a public meeting anyway. So effectively, it's in the public domain.
Okay, well, yeah, we can discuss this further, but I think it'd be fantastic. Certainly, from a political point of view, if you've got a manifesto and things you're trying to work towards, to just be transparent about how you're doing. Hema and then Charlotte, thank you.
So when we did the health and wellbeing strategy and we had the stakeholder engagement, one of the things which we had agreed is we will publish in due time how we are progressing on the delivery. So I think my view is that we should be publishing. Most of the data that we're using, the outcomes are which we agreed as a system. So they should be available. So I don't think there's anything which within the system, the outcomes, indicators we had, which are not available for public. There may be things when we are progressing that we look internally, which we won't put on the dashboard.
Yeah, and I just add to that with time, it's our vision to enable all of our partners right across the system to use the data proactively to inform how they deliver their services and their support, and for us to not only have a backward-looking vision of what the data is telling us, but to start to look forward to help with our planning and our forward thinking. So it has real it's the foundation for us to really sort of use it as the bedrock as to how we should be evidence basing our decisions and our services moving forward.
Councillor Wright, I think you're muted.
Yes, I am. Sorry.
Missed that bit. Sorry.
I just said that Grania has put a message in the chat saying could it also be accessible to commissioners, and of course, yes, would be. Okay, I'm aware of time and we're quite behind, so are we all right to move on to the next agenda item 8, which is the dental access paper? And I think that's being presented by Hayley. Is she on the call, or is it?
Hey, good afternoon. Yes, I'm here. Can you all hear
Hi,
me?
nice to meet you.
Hi.
Yeah.
I'm actually new in post, 4 weeks, and I'm actually here with my colleague from the South East Commissioning Hub, Michelle Ross. Is Michelle on the call as well?
Here.
Oh, fantastic, Michelle. Thank you. It's just generally today to give a general update about the commissioning of dental services and our role as NHS Frimley Integrated Care Board in those services. So there we go, the slide deck's being shared. I'm going to hand over to Michelle. If anybody's got any questions afterwards that we're unable to answer today, obviously we'll get back to you as soon as we can after the meeting. So I'll hand over to Michelle now.
Thank you. Can we move on to the next slide, please? Okay, so as Hayley said, this is really just a general education on dental commissioning. We recognise that the Health and Wellbeing Board originally asked us along because they had heard of issues with accessing dental care for looked after children. And just to say at the outset, we've investigated this with the relevant Bracknell Forest council team members, and it's no longer an issue. Like all patient groups, it was an issue during COVID-19, but it seems to have resolved now. In terms of the background to dentistry, so the pharmacy, optometry and dentistry commissioning and contracting functions were previously carried out by NHS England. The responsibility for these services was transferred to the 6 integrated care boards in July last year. The purpose being to allow for local needs to be considered in the way that we commission dental services. We do recognise that we are still recovering from the effects of COVID-19, but as we'll go on to see, Frimley is recovering, and we're working to ensure ongoing and future access, particularly for vulnerable groups of patients, for instance, clinically vulnerable, looked after children, homeless patients, and patients who live in areas of high deprivation, but obviously that list isn't exhaustive. Can go on to the next slide, please. As you will see from this, although we have a way to go to get back to pre-COVID levels, we are starting to see progress. And Frimley, showing in the top dark orange line, is actually showing a better recovery trajectory than the other 5 ICBs in the South East. Next slide, please. So this map shows a distribution of commissioned practices and community dental services. These have a combined budget of 45 million. Sometimes dentists will hand back their contracts and cease doing any NHS work for us. Fortunately, Frimley's in a very good position. They're very stable. We've only had 2 handbacks in the 4-year period, the last 4-year period. We've managed to re-procure the majority of the units of dental activity that were handed back. We still have to find providers for around 4,500 UDAs, and we're looking to re-procure these imminently. Next slide, please. The problems that we are experiencing in Frimley with recruitment are just very reflective of the national picture, and that's all I can really say about that without sort of overlapping onto other slides. We'll move on to the next slide, please. So bear in mind that the dental recovery plan is national, so not everything here may apply to Frimley, for instance, the mobile dental vans, because these have really been targeted at areas where access is difficult due to factors like rurality, if that's a word. There is a focus on early intervention and prevention, as well as increasing our future workforce capacity. Move on to the next slide, please. So we are undertaking several national incentive schemes, such as the Golden Hellos, where we're encouraging dentists to come and work in areas that have been traditionally hard to recruit to. This is in progress at the moment. ICBs are working together on a process for dentists to apply for funding in times of need. We also have the 10% overperformance payments. So dentists are expected to only perform up to 102%. That's their upper limit of their contract value. Last year, we allowed them to go over by 10%, and 38 surgeries in Frimley actually took advantage of this 10% overperformance in the 23-24 year. Next slide, please. Oh, it's gone. Oh, there it is. So we are seeing an improving picture in patient access, including with the previous identified areas of patient cohorts, such as looked after children. Like with all other patient groups, access was very difficult during COVID, but this has been, as I mentioned previously, it's been resolved. We're looking in the future to work collaboratively with general dental practitioners to resolve any ongoing access issues and target areas where the need is greatest, for instance, areas of high deprivation. We do recognise that urgent access is an issue, but we're looking to address this in the way that we commission future activity and via national initiatives. Any questions?
Thank you. Thanks very much for that, Michelle. I can see Charlotte's got a hand up. Charlotte?
Yeah, thanks, Michelle. That's a really useful overview. A couple of questions, just in terms of how you now work with NHS England and the dental public health teams that sit within NHS England that bring that expertise in terms of the data and the epidemiology with respect to dental health and oral health, and also the evidence base with some of these national programmes that are going on and how they're evaluating. And is there any opportunity, we know in Bracknell on the whole, and I'm sure this is the case for dental health as well, we're largely healthy and wealthy, but there are these pockets. And so is there opportunity for us on a local level to learn from some of these national programmes that are happening elsewhere that we could apply in a very targeted way? And I just wondered how that relationship was working so that we can learn from those national programmes.
We're still definitely linked in with dental public health. We have their input into a lot of our procurements, for instance, that are running currently or are just about to start running. In terms of the way we commission general dental services, the IMD, the index of deprivation, is very much reflected in the way that we commission these services. So, for instance, in an area where the deprivation is likely to be higher, traditionally those dentists have received higher rates of pay for their services. So that's one way we try to mitigate against that. But certainly we're sort of seeking to find ways to use that information to inform any kind of future commissioning. services, in particular services, for instance, like unscheduled dental care, special care, restorative, oral surgery, all that is all been factored in to those.
Apologies, can I jump in if that's okay? I'm not used to Zoom and I don't know how to raise my hand on this. My role at Frimley ICB, thank you, Michelle, that was absolutely fantastic, and you're absolutely bang on how we're working together. My role is a transformation role with Frimley ICB. I've only been in the role for 4 weeks, and a huge factor of that is how we work together, particularly with public health and all of the ICBs across the southeast and all of our local authority areas about transforming dental services across the patch. We are obviously looking at the flexibilities within the contracts that Michelle was saying, and how we can best work together moving forward. I know Nicola will probably want to say something further about this.
Thank you. Andrew did have his hand up before, but Nicola, was there anything you wanted to add to what Hayley was saying? Or
Well, I was just going to come in on Charlotte's point. Hayley, I wonder if we could take away an action to work out how we can make the connections better between the dental public health team and actually our 5 public health teams within our system. When I was doing dental commissioning, it wasn't that straightforward to make those connections. I think they're quite a small team, so we need to be really mindful of doing that efficiently and effectively. But to help Charlotte, perhaps we could help facilitate those conversations.
That'd be great. Thank you.
Yeah, you're right, Nicola, it's 2 people.
thank you. And then if we go to Andrew, and then after that, Gronya, please.
Yeah, thanks. So thanks for that. That's really helpful. My question is a bit more about data, and I suppose looking in there, we've got that little bit of data about the 83% of patients being able to get access to a dentist. But I suppose for Bracknell Forest, we're interested in, are there enough NHS dental spaces for our population? Are our population getting the annual regular, what's the uptake of taking an annual dental appointment? And then thinking a bit further on about the links that dental health has with some of our other issues. So most recently it's been linked, gum health and dementia, etc. So what are we doing in the space that says this is an important preventative measure for other factors? So just a question about the data and about what those sort of pathways that we're looking at might be helpful.
It's really tricky to get hold of reliable data, mainly because so when a dentist sees a patient, they will fill out an FP17 form, which then gets uploaded onto our system Compass. And it's really dependent on what they put on that form. And there's certainly nothing there around those that they can put on about those risk factors, for instance, which I know I would find very useful. So it is something that we're seeking to address, definitely. Because we don't have that clarity in data, it's quite difficult to understand fully who's not getting access to appointments or dentists or to regular checkups, for instance. I found it quite frustrating because I came over from elective care 6 months ago, where our access to data was much, much better. Yeah, so that is something that we are seeking to address, and we are dependent on our public health teams to give us a lot of very useful data around deprivation, around risk factors, around health-seeking behaviours, to help inform us.
Just coming back, do we have an idea about whether there are enough NHS spaces for our population? That was the other question, or is it? Are we unable to?
That's
confirm
difficult
that?
because we don't necessarily know how many patients are actually utilising private dental care, because dentists don't need to declare that. So we're kind of working blind almost, or partially sighted, if you like. We can certainly see how many units of dental activity are being used up every year. but that doesn't necessarily tell us how many patients we're seeing, because one unit of dental activity does not represent a patient because of the way the banding structure works. So, for instance, band 1 treatment, which is just a checkup with x-rays, etc., is just one patient. However, that patient might need a lot more treatment, which is band 3, which is 12 UDAs. So it's a lot more complicated than just saying, oh yes, it's this many UDAs have been used up, they're seeing this many patients. That's not the case. It's something that I'm trying to get to the bottom of, because I am part of the recommissioning programme for special care and paediatric dentistry, and trying to get to the bottom of that data has been a huge challenge.
Okay, I can see Nicola's trying to put a hand up, but is it on this? Because Granya's also had her hand up for ages as well. Is it just a quick point, Nicola?
Yeah, I think, Andrew, at a very basic level, our dentists are busy. We're not up to pre-COVID levels, and not everybody is saying they're able to access a dentist. And we have ring-fenced dental budgets still to spend. So I think at a basic level, we are still trying to increase the capacity of dentists in Bracknell and across the system, even if we don't know the exact numbers.
Okay, thank you. Thanks. Grania, sorry, thanks for your patience.
No, that's fine, and it is just further supplementary. So I don't expect the question to be answered given the responses that have come through so far. But we're trying to get a greater understanding of so health needs assessments, etc., for disabled children leading into early adulthood. And so when it comes to children, disabled children specifically, autism, etc., trying to understand their journey through childhood into being a young person, then into adulthood. And again, we have no data in relation to that, or nothing that we receive regularly. So I'm really keen for us to be able to get more forensic in terms of what those data sets look like, because we all know, I mean, one of the factors might be people who then go into crisis and have to have urgent medical attention due to not being able to access services in a timely way, or more of the specialist provision. So I'm really interested in that part. At the moment, Public Health are undertaking this health needs assessment for disabled children into adulthood for us, but it'd be helpful if we could have an indication of access to all sorts of care, including dental care, as part of that.
Grania, have you been in touch with the Dental Public Health? So you've got Jonty and Aditi.
Can I come in there?
Yep.
If that's okay, Chair. So, yeah, I think to answer some of these questions, we do have the Dental Public Health team coming to our Berkshire East meetings on a regular basis, to just update us and do that. So we do work very closely with them. Charlotte, you'll be pleased to know. We also had an internal meeting after you raised that chair about children with looked after children and children with disabilities accessing dentists. So both from the ICB, Lauren Pennington and Ian Pinky, and then from our children's services, the lead for those areas, we met together to see what the issues were. And what we have been told by the services is that whenever they need to, for the annual check, whenever they need to access dentists, they can get a placement. For the younger children, it's easier because they do take on the guardian or the parent, foster parent, whoever may take them, and they take them. The older ones, those 15 plus, although they're offered, it's up to them, and many of them don't take up. So it's more about them not taking up the offer of the dental appointment, and perhaps that's where we need to work in terms of why is it they're not taking up. So I think we did go through that to understand, and as Michelle has said, there's no indication whether a child is in care or has diversity, but I think from the people who are leading who said, we can always find somebody, a dentist, to give the appointment. In terms of the question that Andrew raised in terms of dementia, gums, this time when we are doing the oral needs assessment, so it's coordinated by the dental team. I have asked, and they've agreed to that, if we can do a survey of older people, especially nursing homes, because this time, every year they've got different cohorts of people they do oral needs assessment. So this time they're doing nursing homes. So hopefully, we'll get some data from that back to us in terms of how care homes and what are the issues in terms of dental needs for care homes. And as part of that, they also be doing some impact of malnutrition, etc. So there is work going on, and maybe in future we need to ask them to bring it to this health and well-being board so that we're all cited on that. So I just
Okay,
want to
thank
do a bit of background and things that are
Thank you,
happening.
Hema. Thank you. I'm quite conscious of the time, and we've still got two quite meaty things on the agenda. Is there anything else anyone wants to add on this? No, thank you very much, Michelle. Thank you very much, Hayley. Really good, thank you. Obviously a lot to discuss there. If we can move on to the next agenda item, which is the new Frimley Park Hospital build. And I think we've got Kane Thomas with us, I believe, who's going to be talking to us.
Good afternoon.
Okay. Hello. Yeah, go ahead, Kane. Thank you very much.
Thank you. Good afternoon, Chair, and good afternoon, members and colleagues. I'm joined by my colleague Robin, who's going to present and open the presentation. And if I hand over to Robin, thank you.
Hi everyone, nice to meet you. Sorry, I'm trying to find my way around Zoom, so I've lost all the speakers. One moment. So lovely to meet you. Just working through. So as Kane mentioned, I'm Robin. I'm the Assistant Director of Engagement here at Frimley Health, and I think if you haven't met Kane before, which I don't think many people have, he's our Interim Programme Director. So just to begin with, sorry, I'm trying to get it to work. As you will be aware, the government recently announced a full and comprehensive review of the National New Hospital Programme. So we all know about this. And it said that while it's undertaking this review, it will continue to deliver the most advanced and most urgent hospitals to a realistic timeframe. And if you're watching Prime Minister's questions this week, the PM said that hospitals with RAC must remain a priority. And it was great to see the Secretary of State nodding for health, nodding in agreement with that. So in parallel with this national review and this refresh, we've been looking at our own internal leadership within the trust and our new national hospital programme. So our new Chief Executive, Lance McCarthy, joined us about a month ago now. And our we've also got a new Senior Responsible Officer by way of Caroline Hutton. So Caroline has a lot of very senior programme experience, and very recently actually was the Senior Responsible Officer for the EPIC programme. So that's our electronic patient record, which I'm sure many of you are aware of. So we've got Lance having just joined us, Caroline, and we also now have a new permanent programme director, Alex White, who's come from West Herts. So both Lance and Alex have got extensive knowledge on new hospital programmes and developments like this. So that's going to be really, really beneficial to the programme. So we're using this time to work really closely with the national and regional partners to understand a little bit more about what, if anything, this review of the programme might look like for us. And any new expectations that we might need to meet in order to be ready for 2030. So as a RAC hospital, we remain an absolute priority. We have some 8,500 RAC planks at Frimley Health. So that's around 65% of the current site at Frimley Park. And we are absolutely committed to continuing that work as part of our new hospital programme. So we haven't slowed down. We haven't stopped doing anything. We're working as quickly and efficiently and effectively as we can. So just to give you a little bit of background about the trust, just for anyone who's not aware. So we are a very, very big trust. We have around 14,000 staff serving approximately 900,000 patients across 10 sites and in people's homes as well. So we provide a range of both regional and tertiary specialist services, including PPCI, which is a heart attack treatment, stroke thrombolysis services, vascular services, cystic fibrosis, renal cancer. And for renal cancer, it's probably a population of more like 1.4 million patients across Surrey, Hampshire, Berkshire, Buckinghamshire, and Outer London. We have a range of innovative and integrated community services. So we're starting to do a lot more work out in the community where we can. We have a fantastic virtual ward system where patients
are being kept at home where it makes sense and is better for them to do so, but being monitored very closely by clinicians within the hospital. And then, of course, we're looking at other urgent and community services working in very close collaboration with our ICB and ICS partners. We have two key district general hospitals, our two acute sites, so Frimley Park and Wexham Park, both of which have seen an enormous increase in the amount of emergency attendances to our EDs over the last couple of years. So it's between 400 and 500 patients quite frequently now on any given day at either site. So it's not unusual now to see in excess of 400 patients per day to each ED. So that's obviously putting a huge amount of pressure. Just to move on, I'm now going to hand over to, that's a quick bit of background from me. So I'm going to hand over to Kane, who's going to take you through a little bit about the RAC and just where we're at with that and how we're continuing to provide remedial works.
Thank you, Robin, and thank you for excellently setting the scene there. So RAC, reinforced autoclave aerated concrete. There's no permanent fix. And as Robin has alluded to, just under 65% of our hospital was built with RAC planks. If you're not clear on what RAC looks like, if you put that into a search engine and have a look at some pictures, then you'll see it looks somewhat similar to an Aero chocolate bar when you look inside as a cross section of what RAC looks like, and that's deteriorating. So since 2019, we've been doing an extensive and significant program of works to make sure that we can keep our hospital safe for staff and patients and continue to operate there. And by the end of this financial year, we would have spent nearly £30 million making sure that our hospital is safe and can continue to operate. There is, let's say, the significant works. We've dealt with the high-risk areas in ICUs and theatres to making sure that we can continue to operate in those areas and continue to do the remedial work so they're safe. It takes a huge amount of planning to be able to undertake the reinforcement and the remedial works, both from an operational effectiveness, from services and from building effectiveness, but also operational continuity from a clinical setting and in infection control compliance. It takes months to plan in terms of decanting clinical functions, then having clear access to do the works and the reinforcement and the remedial works, and then move services back in and then start to the next area. Going into the autumn, we would have finished all of our theatres, and we're currently just in the process of concluding our PEDS wards, which is a highly sensitive piece of work to configure and deliver. But we will continue to make sure that the hospital is safe to function, and operational continuity is maintained throughout the process of building our new hospital. And that is very much an ongoing process. Next slide, please, Robin. Thank you very much. So on the new hospital program, of which Frimley is part of, we joined the new hospital program in the spring of 2023. And we concluded that our preferred way forward was a new hospital on a new site. The modelling work that we've done tells us that the size of our new hospital will be in excess of 130,000 square metres. That's twice the size of our existing hospital. And that's, if anyone can picture our Heatherwood facility, that's 12 times the size of Heatherwood. We know it's going to cost us a capital investment of over £1 billion. And given our critical success factor to deliver this new hospital, given the RAC that we have in the hospital, it has to be ready for 2030. We know it's going to be a much bigger hospital, and in terms of the demand and capacity modelling that we're doing is telling us it will have more inpatient beds. And we're working with our colleagues in the ICB to determine the number of inpatient beds and the number of community services, community beds they will be providing. And that work is happening in tandem with our design at this moment in time. So being part of the new hospital programme, we are adopting something called Hospital 2.0. And that involves using modern methods of construction to deliver our hospital, in terms of the best practice and flexibility in design. The pandemic taught us that major acute facilities, just district general hospitals, have to have flexibility in terms of repurposing. And all of those are taken into consideration in Hospital 2.0. It is, in effect, a templated design for certain areas, such as our wards will be single rooms, 32-bed wards, all single rooms. It will be a net zero carbon building. It will be an all-electric hospital, and the digital enhancements of this hospital will be like no other hospital in terms of accounting for significant benefits across the whole of the hospital and how we operate the hospital as well. If we can go on to the next slide, please. So I'm going to talk a little bit now about the site selection process that we have kind of walked through and moved through since we came onto the new hospital program in the spring of 2023. So in the summer of 2023, we engaged a land agent to look at possible sites, knowing what we knew in terms of the size of the hospital and the services that we would have on our new hospital site. We engaged a land agent to look at possible sites. And that gave us a long list of possible sites that we could consider. And of those sites, we then applied what we called a hurdle criteria. And this hurdle criteria aligns to the options filter framework of the Treasury Green Book in terms of investment for public money and the business case process. That hurdle criteria involved appraising sites. Were they big enough? Could we fit a new hospital of the size of Frimley on these possible sites? Were they deliverable and developable for our critical timeline of 2030? And were they within 5 miles of the existing hospital? And that was the hurdle criteria. Along with, of course, was there a landowner willing to sell? And once we applied that hurdle criteria, that then brought us down to a number of sites that we designated priority sites. So we were reducing the number of sites that we knew would be viable for a new hospital. In tandem, we did an engagement exercise towards the end of 2023 and listened to the community, patients and staff of what was important to those individuals and members of the public for their new hospital. And we played that into our site selection process when we developed a detailed evaluation criteria. And we played that evaluation criteria into the next phase of our due diligence. And that landed us on preferred sites, a number of preferred sites. So we went through that cascade process of a long list, reducing that to preferred sites through the process of hurdle criteria and then the evaluation criteria. Let me go on to the next slide, please. And that evaluation criteria was, as you can see at the bottom of that slide there, those headings in terms of the pictures were the evaluation criteria that we've applied to our preferred sites. Looking at those preferred sites to see how they stand up to detailed design and due diligence on all of those areas. We have a team, a professional team of architects, engineers from all different disciplines. We have land agents, lawyers, economists, all kind of across the professional services supporting us in the development of our due diligence on our site studies to tell us, can we fit a new hospital? Can we operate a new hospital on these sites? And what does it mean to the local environment, from our patients, from our staff, and the local environment as well, with a new hospital on our preferred sites? And that's the level of work that we've been doing, studying each of the sites. This technical due diligence that then is appraised and ranked and developed. We've been able to develop key risks and opportunities for each of our preferred sites using the evaluation criteria that you can see there at the bottom of the screen on the presentation. What we've then done, we've engaged with our local planning authorities for the preferred sites, and we've presented our master plan. So we've given them the master plan that has our new hospital on there, albeit still in a very early indicative design, to just walk through the the size of that hospital, the massing of that hospital, how it fits into the local environment. What are the risks in terms of the utilities diversions that we need to consider? What are the services that we need to pull in? And a really important one in terms of transport. How people will access the new hospital from all types of transport modes, in terms of active transport and private transport and public transport as well. We've modelled the highways in terms of the capacity on our preferred sites. We've looked at the junctions in a significant amount of modelling detail to understand what works we need to do to improve the facilities and the local infrastructure. We've discussed that with the local planning authority through a process called a pre-application and a planning performance agreement. And that's given us vital and really important feedback from our local planning authorities based on how we progress our preferred sites once we conclude our site selection process. We've also done the same process with the County Highways Authority and some of that transport modelling that I've just touched upon. And that's given us some really good feedback, and we've got detailed reports from all of our local planning authorities and county highways authorities about how we could progress and conclude our site selection process, and what we'd have to do in the future once we submit an outline and detailed planning application to gain consent to build on our sites. We've done that in tandem with commercial negotiations with those landowners. And we've done all of that under the confidentiality blanket of non-disclosure agreements. It's really important for our commercial negotiations that we protect those at this point in time to ensure that we can progress through our business case process and secure the best value investment for our new hospital in terms of land costs. It's also vitally important for those landowners as well, because some of those landowners do have businesses operating on their preferred sites that we're looking at, and we need to protect that at this moment in time because we have a number of preferred sites, but we haven't concluded that process. So we're doing the discussions with the local planning authorities and the county highways in tandem with those commercial negotiations with landowners to secure the land when we choose and conclude our site selection process. So what are our next steps? Well, during the summer, our pre-application process, some of the feedback that we had from the planning authorities was there's some ecological and environmental work that we need to do, more so than we have done. And we really need to look at that in more detail in terms of the impact on those preferred sites. We need to do more in our equality impact assessment and the duty that we have to our community and to patients to understand the impact on our catchment to a new hospital on any one of the locations that are our preferred sites, and how would we manage that, and how would we protect those characteristics in terms of the equality impact assessment, and how would we mitigate the impact of moving a hospital to two sites, so to a preferred site, and that's where we need to get to. That's the detailed piece of work that we're still working through to conclude the process. So that is a whistle-stop tour of what we've been doing. That's a number of years' work from a considerable amount of people and organisations and agencies, summarised in about 10 minutes. So I appreciate there will be a load of questions on many aspects that I've covered there, and I'm happy to try and answer questions as best as I possibly can at this point in time. Thank you.
Thank you so much, Kane. I can see Andrew got his hand up first then, and then it's Hema next, I think.
Kane, Robin, thanks very much. That's a sort of progressed on from the last presentation we've heard. Just from a timescale perspective, have you got an indication of when it's likely to go live on the preferred site? So have you got the point at which you're likely to put a planning application into one of those local authorities?
We have an indicative timeline, but at this moment in time, first and foremost, we have to conclude the site selection process, and we have to do that as soon as we can. And we're unable to give a definitive timeline at this moment in time when we will conclude the site selection process and then move towards a planning application for our preferred site.
Okay, thank you.
Okay, thank you. Hema, have you got a question?
Yeah, so thank you very much. And you did say, there are lots of stakeholders and professionals who are involved in this project. My question was that we know from evidence now, especially from Europe and other places, about healing and designing for healing, especially for hospitals, because we know people who are ill, they are more sensitive to the senses, and people who work in hospitals are also working under stress. So there's a lot of interest now in how do we design hospitals for healing. So how do we create the spaces which are more healing spaces, yet have the the more technological aspects as well. So I'm wondering whether you've looked at those aspects, especially from examples from Europe, in
We
designing the
we have
hospital.
yes, yes, Hima, we our professional team in terms of our architects and our designers and engineers are some of the best healthcare um, consultants in the UK with years and years of healthcare experience. So we're looking at all aspects of how our design can complement a new hospital that will be in place for many decades to come. So it's very early in the process. We're still in the master planning of a piece of land. We're not into the detailed design of a hospital yet, but we will consider all of those facets that make a modern hospital for the future.
Thank you.
Thank you. Thanks. Have we got any more questions? Okay, I've got a question. It says by the end of 24-25, you'll have spent nearly 30 million on a survey, safety, inspections, remedial works, etc. I'd just quite like to understand the trend of how this money's being spent. Like, is that money increasing as the building gets older, or was there a lot of money that was spent initially to kind of make the places? I suppose what I need to understand really from a sort of political point of view is the longer we leave this, is that 30 million going to increase more, or is it going to sort of stabilize around a certain number? Like how much is it costing us to make as we're waiting for this to go on?
I guess, Councillor, that there's two aspects to answer that question. The first aspect is we can't. This isn't a permanent fix. There isn't a permanent fix for us.
I understand that.
So we have to have a new facility at a point in time to do that. So we can't keep on going in terms of investing money for remedial works. The other element is we've dealt with the really significant areas in terms of the critical areas, ICU, theatres. We've dealt with those really complex areas early on in our remedial programme. Not to say that other areas are less important, but the complex areas that would really affect our operational continuity, we've dealt with. So that plays into our contingency planning. So there will still be a significant capital spend whilst we are continuing to develop a new hospital. We've dealt with the significant areas, but we still have a lot of work to do to make sure our hospital is safe and a detailed programme of remedial works to do.
And just out of interest, how many hospitals are there like Frimley that have this rack issue, and how many are? I mean, Frimley's. I mean, is it about a third of Frimley's rack? Is that right? Yeah.
Yes, it's about sorry.
Yeah, and how many are similar to that? Do we know?
That within the overall new hospital programme, there are 7 rack trusts, of which Frimley are one.
Okay, 7. Okay, all right, Alex. I can see you put your hand up there. Was that to do with this point?
Yeah, well, it was to reiterate the point Kane was making. There are 7. I thought we were 65% rack on our site. And just to, I guess, reinforce the point that Robin was making earlier, the NHP have confirmed, in fact, that the rack schemes are exempt from the review that's being undertaken by the government. So it's a slightly stronger, I think, position than being prioritised. We're exempt. And I think that's really key.
Thanks, Alex. Yeah, if there are no other questions, there is a section of engagement that Robin's going to cover now to finish our presentation.
Hi, I'll keep it really quick because I know you're running slightly over. So this is just to give you an update on where we've been with the engagement, our commitment, and what we're planning to do going forward. So we are absolutely committed to engaging not only with our staff and patients, but very importantly with volunteers, our local communities, other stakeholders throughout all stages of this. So we've developed some equality and inclusion principles to help make sure that we reach those slightly more underrepresented communities, or those that use more traditional methods of communication, and those that are likely to face barriers, whether they be language or because of their accessibility needs. What will help us do this is a big piece of co-design work that we will be working on with our Health Watch partners or colleagues in Health Watch, and they will specifically go out and have some really in-depth conversations with communities, specifically looking at those areas where people possibly speak English as a second language, or maybe they have learning difficulties, they might have additional communication requirements. It could be under unpaid carers, seldom heard communities, parents with carers of young children, young people, deprived areas. So those areas that are just slightly harder to reach or might need a bit more. That will all then, that full report, which will be published after the work has been done, will all feed into our communications and engagement programme. So as Kane mentioned earlier, from the 24th of November last year to the 7th of January, we went out and heard from as many people as possible. We had 3,400 people came and responded to our online survey. We held 5 public listening events, 8 community engagement events, and we had 2 all-staff events that were made up of stakeholders. So all of that feedback was then summarised. And that helped us to identify what those key things were that were most important to people as part of that site selection process that Kane referred to. So, for example, it showed us that 56% of those respondents said that access by car was the most important. 35% said distance from the current site, 31% access by public transport, 25% said everything was equally important. So what we did was we took that, and that helped the weighting of how we then selected down from our preferred to our priority sites. Those reports, there's the in-depth review, which is the picture that you can see here, and which was independently done, and then a summary you said we did are available on our website, or if anybody would like me to send the link directly to them, just pop me a note in and I will do that. Sorry, doesn't seem to want to click forward. Next slide. I am terribly sorry. There we go. So what matters now is understanding how moving a hospital is going to impact our workforce. So we know a lot of things about our workforce. We know how many people we have. We know how many of those work on the Frimley site. And we know the breakdown of the types of roles they have, how far they generally live from the current site, and their age group. So that would help us with things like identifying how many possibly might retire by the time we open the new hospital. So these are the kinds of things that we then still want to find out. So how do our staff currently get to work? Is it by car, train, bus, walking? We have quite a lot of staff who walk or cycle to work. As I mentioned, how many will be retired by the time we have the new hospital? And all of that will then feed that alongside the work from Health Watch, and all of that will then feed into our communications and engagement strategy. Be pleased now, I have only one more slide. So just to summarise, we are absolutely committed to ensuring that our staff, particularly those that are directly affected, hear through us first on what we're going to build, how we're going to build it. We want to keep our staff engaged, and we'll have various bespoke events. We've just launched a roadshow today, which will go around all of our sites over the next 3 weeks, chatting to staff and giving them the opportunity to ask questions. Existing channels and meetings will be used for staff, and we've also started new channels which are internal and externally available, such as our WhatsApp broadcast channel. So we have advertised that on social media and also through our newsletter that we do on a monthly basis. We have events and staff briefings. There'll be opportunities for line managers to hold sessions with more information. And we'll be aiming for departments, both clinical and non-clinical, at all of our sites to have a named ambassador, so we can really start to have that direct link and engagement over the next few years. So it's just reinforcing the importance of the external and the internal engagement that we will be doing throughout the duration of the programme. And that's it.
Thank you very much, Robin. I'm really aware of time. We're really pushed because we've still got one more agenda item. I can see Nicola Aries put a question in the chat. Nicola, should we ask that? That's just about how we're managing co-design with them.
Yeah, Robin,
yeah, go for it, Nicola.
Hear how important it is to engage with people and communities and your staff. There's another cohort that for whom this service needs to work for, and that's people who refer in and receive people out. And I get frequent questions from both ICB staff and actually from other providers to say, actually, what's your co-design engagement process with provider colleagues? And I just wondered if it's interesting in your slides, whereas there are for people and communities and for staff.
That's really helpful, Nicola. We are actually working as one single team with our ICB comms colleagues, so Ellie and Steve and Nisha. So we're all working as one team, and Steve is leading actually largely on some of this. So I'll take that back and make sure that is fed into our plans. That's really helpful bit of feedback. Thank you so much.
Thank you. And Alex, you've got a question?
Thank you. I'm just going to build on that really. So my name's Alex Guild. I'm Deputy Chief Executive at Berkshire Healthcare, with a community provider in this area in East Berkshire. I think for the new build to be really successful with the demographics and demand and population growth, we've got to have a strategic discussion with ICS partners about the out of hospital provision that you do reference in your slides, and it's timeline and engagement for that strategic conversation really about developing out of hospital to ensure the hospital is really successful and seeing only what it needs to see inside those walls using those beds.
Definitely agree, Alex.
Thank you. Okay. Thanks everyone. Any more questions on this, or should we move on to agenda item 10, which is the new place governance arrangements, which I think is you, Nicola, isn't it?
Ronnie and I are going to do a double act,
Fantastic.
which won't be as entertaining as it sounds, I'm sure. Just to give you the context of this, the board will remember that the reason we're looking at governance is because the ICB has restructured itself as an organisation, and we've taken that opportunity to look at our governance. We've retained the 5 places construct, with Bracknell Forest being one of those places. We've had a workshop in July with our local authority colleagues, and each of the 5 places is now implementing a framework around place governance that we agreed. And at that point, I was going to hand over to Gronich to just say where we're up to in Bracknell Forest.
Yeah, no, thank you, Nicola, and very helpful summary there in terms of where we're at. We did find it helpful that the ICS, our ICS colleagues did listen to each of the local areas about wanting to retain a unique governance structure at a place level. So that was really positive, but fully accepted that there would be less capacity to service that. So we did think about what we needed. So from our perspective, the work that we've done in the background is we've accepted we will retain a Children Young People board for the purpose of collaboration and local discussions, including a Children Young People plan, so that collaboratively with health we'll be able to demonstrate or continue to demonstrate our joint working and integrated arrangements for the delivery of health priorities for and care priorities for children. So that's really positive to note, and we'll be moving to a quarterly structure for the Children Young People board from the governance from that perspective. We've also had discussions about what this means in terms of replacement for what is currently called the Place Committee. So conversations about terms of reference and frequency, and that work is continuing. We have come up with a framework of the meetings and including a face-to-face workshop in addition to the quarterly meetings. So the principle of agreement from that perspective. The last area that we're still working through is how the delivery arm of the health and wellbeing strategy development is undertaken, and because we just need to work through the nuances of that to make sure we don't lose the strategic oversight of that health and care partnership board, let's call it that, the current place committee, through it turning into really a working group about the health and wellbeing strategy. So those conversations are continuing in the background. So hopefully by the next Health and Wellbeing Board, we'll be able to present what those local governance arrangements are. But it just to confirm a positive approach to working in partnership still at a local level, albeit accepting the frequency of the meetings will be less. But we'll continue to develop a health and care strategy or plan, so something that we're doing together instead of having an individual adult social care plan or health plan at a local level. We're committed to having a joint one, and the same from a children, young people perspective, sitting under the health and wellbeing strategy and the other key strategies within the ICS. So, but we just have a few more things just to finalise before we're able to put forward a paper.
That noise is. Thank you. Have you got any questions on that? I just had a quick question with regards to GP sort of what do you call it? GP councils and the patient participation group. Is that coming under the new model? Is that part of it?
No, Megan, but
Yeah.
I can take your question and get an answer for you if you want to drop me an email.
Okay. Yeah. All right. Yeah, because that was one thing that someone was asking about. That does the new model affect this? And then
so the simple answer to that, Megan, is it won't affect it.
Okay. All right. Fantastic. Fantastic. All right. Thank you. Any other questions? I mean, that all sounds quite sensible because I know. All right, go for it, Philip.
Sorry, I couldn't find my my hands up icon. And my only question really is, we're obviously going to be having fewer meetings. I'm just aware of volume and how we might manage that volume. So it's an operational challenge for us moving forward. But hopefully we can build that into the terms of reference and think about whether we need to have any extraordinary meetings for particular purposes, work streams that come out of these partnerships into the future. Thanks.
Thanks for that. I'm sure that's noted. All right. Okay, thank you. Thanks for your work on that as well. That's good to hear. All right. I think if there's no further questions on that, we're not discussing agenda item 11 because Health Watch aren't with us today. Agency updates, number 12. I can't even quite remember what that means. Does that just mean from like you guys, if there's any updates? Do we have any updates from anyone? No. Okay, thank you. I also noticed that we've got the self-care week at the end of October, just to let everyone know. I saw we got information about that. All right. Okay, after panicking that we weren't going to finish in time, Grania is very quick. So thank you very much, guys. Yeah, really good meeting. Thank you. Thanks to everyone who's presented.